Hey everyone, welcome back to the channel. If you are aiming to crush your dental prometric exams and ace your clinical rotations, you are in the exact right place. This is part 13 of our high yield Q&A marathon. And just like the previous episodes, we are diving into another set of 10 essential questions. We aren't just memorizing high yield facts today, we are breaking down the exact clinical why behind every single answer so you can apply it in the clinic. So let's kick off today's video with question number 1. In the primary dentition, the mandibular foramen is located where in relation to the plane of occlusion? Is it A, higher than the plane of occlusion, B, much higher, C, lower, or D, at the exact same level? The correct answer is C, lower than the plane of occlusion. So take a look at the diagram. When you are giving a dental injection to a child, developmental anatomy changes everything. In adults, the mandibular foramen sits right at or slightly above the chewing surface. But in kids, the primary teeth, that mandible is still growing and lengthening. As you can see illustrated, the mandibular foramen sits lower than the plane of occlusion. This means to numb them up effectively for an inferior alveolar nerve block, you actually have to alter your technique. Aim your needle slightly lower and more posteriorly than you would for a grown-up. Keep that little anatomical shift in mind for your pediatric clinic rotations. So let's move right along to our next question. What is used to protect X-rays from cross-contamination? Is it A, barrier film packet, B, digital X-ray, C, chemical solutions, or D, none of the above? The absolute right answer here is A, barrier film packet. Think of a barrier film packet as a tiny custom protective raincoat for your dental X-ray sensors and film. In our world, cross-contamination is an absolute deal breaker. Since we can't exactly toss high-tech, expensive digital sensors into a heavy-duty autoclave sterilizer between every single patient, these disposable plastic pouches step up to save the day. They completely block out saliva and bacteria, keeping things perfectly hygienic. Once the X-ray is done, you simply peel it off, toss it out, and the sensor stays pristine and ready for the next smile. So that's it for that question. Let's head over to the next question. Patients present with spontaneous pain in the lower right first molar when taking hot liquids and that pain disappears slowly. What is your diagnosis? A. Irreversible pulpitis. B. Reversible pulpitis. C. Apical periodontitis. Or D. Pulp necrosis. The correct diagnosis is A. Irreversible pulpitis. Here is why this diagnosis fits perfectly. The biggest dead giveaway is that spontaneous pain triggered by hot liquids. In a healthy tooth, temperature changes shouldn't cause sudden unprovoked pain. Furthermore, when that throbbing ache disappears slowly, meaning it lingers long after the hot drink is completely gone, it tells us the pulp tissue inside the tooth is severely damaged, ischemic, and simply cannot heal itself. While reversible pulpitis stops hurting almost immediately after the stimulus is removed, irreversible pulpitis lingers on, letting us know the tooth has crossed the point of no return and needs a root canal or an extraction to feel better. So let's move forward to our next question. A clinician can increase the efficiency of a disinfectant by doing what? A. Increasing its concentration. B. Using the disinfectant very often. C. Replacing it every day. Or D. None of the above. The correct choice is A. Increasing its concentration. So think of it like making a great cup of tea. The more tea bags you add to the cup, the stronger and more potent it gets. The exact same logic applies to clinical disinfectants. By increasing the concentration, you are packing the solution with more active chemical ingredients to knock out those stubborn pathogens. More germ-fighting molecules mean they can destroy bacteria and viruses much faster and more thoroughly. While keeping things fresh and clean is always great, simply wiping a surface more often or swapping the liquid out daily won't help if the mixture itself is chemically too weak to do the job. Let's jump right into the next question. All are common materials used under shallow to moderate composite fillings, except which one? A. Calcium hydroxide lining, B. Glass ionomers cement, C. Zinc oxide eugenol, or D. Zinc polycarboxylate. So our big exception here is C. Zinc oxide eugenol. So let's talk liners and bases. When you are dealing with a shallow to moderate composite filling, you want materials that play nice with your composite resin. Zinc oxide eugenol or ZOE is the odd man out here. Why? Because eugenol is a total party popper for composites. It completely interferes with the polymerization and setting process of the resin, leaving you with a soft, uncured, sticky mess at the bottom of your cavity prep. On the flip side, materials like calcium hydroxide, GIC, and zinc polycarboxylate are excellent underlays because they protect the pulp without ruining your composite's chemical bond. So keep eugenol far away from your composite cases. So let's move to the next question. Oroandral fistula persists for more than 6 weeks. What is your management protocol? A. It will resolve with time. B. Antibiotics and nasal decongestants. C. A surgical flap and nasal decongestant. Or D. Dressing and a suture. So the definite answer here is C. Flap and nasal decongestant. So when an oroandral fistula has been hanging around for more than 6 weeks, it's officially classified as a stubborn chronic tract because epithelium has now lined the pathway connecting the oral cavity to the maxillary sinus. It completely loses the biological ability to close or heal on its own. That means simply waiting it out or just handing the patient antibiotics won't cut it anymore. We have to step in surgically. The clinical gold standard here is creating a surgical tissue flap to physically close that communication paired with nasal decongestants to keep the maxillary sinus clear, open and draining perfectly. So remember, if there is a chronic fistula, think right away about a surgical flap. Now let's advance to the next question. What is the best way to remove interdental plaque? A. Proxy brush. B. A toothbrush. C. Dental floss. Or D. None of the above. So the right answer is C. Dental floss. So let's zoom in on those tight spaces between our teeth. While your trusty toothbrush is amazing for the front, back, and chewing surfaces, those bristles physically just can't reach into those narrow, tight contact points. That's where dental floss takes the wheel. Floss is specifically engineered to slide smoothly between the teeth, hugging the natural corners of the tooth structure to physically scrape away stubborn interdental plaque and trapped food particles right at the gum line. Think of it as the ultimate tight space detailer for a smile. So advise your patients to keep flossing and keep shining. So let's move forward to our next question. What is the most common cause of composite failure? Is it A. Voids due to incremental layering, B. Failure of moisture control, C. Excessive polymerization shrinkage, or D. None of the above? So the number one enemy of dental composites is B. Failure of moisture control. So while shrinkage and incremental voids are definitely tricky technical hurdles we have to manage, a lack of moisture isolation is the absolute leading culprit behind structural failure. Why? Because composite resin adhesive systems are notoriously hydrophobic. They absolutely hate water. The chemistry needs a completely bone-dry environment to form a hybrid layer and bond properly with the enamel and dentin tubules. So just a tiny microscopic splash of saliva or blood completely destroys that delicate adhesive layer, leading to micro leakage, marginal staining, recurrent decay, and early failure of the restoration. So always lap on that rubber dam and keep it completely dry. So let's tackle our final question for today. A patient with liver disease will typically present with which of the following? A. Hyperproteinemia. B. Vitamin D deficiency. C. Vitamin B12 deficiency. D. None of the above. So the correct clinical answer is A. Hyperproteinemia. So let's think about the liver as our body's ultimate central manufacturing plant. One of its most crucial daily job is producing essential blood clotting factors including prothrombin. When the liver is diseased, cirrhotic or damaged, its production line slows down drastically. Less prothrombin output directly leads to hyperproteinemia, which heavily impairs the blood's cascade ability to clot normally. This is exactly why your liver patients face a much higher risk of clinical bleeding during surgical procedures, and why you always check their INR and PG levels beforehand. Keep that factory analogy in mind, and you will nail this topic every single time. And this is a wrap for part 13. 10 more high yield questions crossed off your study list. If you found these explanations helpful and want to keep this study momentum going, make sure to hit that like button, subscribe to the channel, and drop a comment below letting me know how many you got right today. Thank you so much for watching. Keep studying smart, and I will see you in part 14. Thank you.